Good morning, everyone. Today I will present about an interesting case of traumatic Bleb leak. This is a 72-year-old female present vision loss one day after rubbing her left eye. This is the only eye due to the ingrowth eyelash. In her right eye, she had a sustained trauma from childhood time, and the vision is only light perception, and she's amblyopic. The left eye had a cataract surgery so many years ago, and then a trap MMC in 2001. In her left eye, the routine pressure ranging from 9 to 21, as documented before in the referral letter. And both eyes has non-proliferative diabetic retinopathy. On the admission day, her left eye, the vision was 120, which was down from 660 as a baseline. And the pressure was from 2 to 3 by Goldman, and we found a pinpoint leak by fluorescein 2%, encapsulated anterior and thinning bleb. Sorry, I could not get the full image of her bleb because her eye was so sensitive at that time. The cornea was clear with decimate 4, AC fluctuating, irregular pupil, and center PCIOL. This is the Optus photo of the fundus, show us a big choroidal detachment. This is the B scan proving the choroidal detachment of the patient. And the impression of the left eye was the bleb leak and choroidal detachment. So we did an urgent bleb revision, and when we opened the bleb, the trapdoor was melting before with vitreous prolapse. We cleared the vitreous by Van Eyck Caesar, and we applied Tutoblast over the melting trapdoor. We trimmed the avascular conch, undermined the conch, and we tried to close the conch. So after the surgery, pressure up and the choroidal detachment resolved. And this is the B scan, anterior segment OCT, and the anterior segment image of the patient after the surgery. So she was discharged 1 week after that with a pressure 22 and the vision back to 660, no bleb leak, and the choroidal detachment completely resolved. This is the patient 2 weeks after the surgery with pressure 14 on Xalacom. You can see there is no leak here with one exposed suture. I will discuss about bleb infection, choroidal detachment, and hypotonic maculopathy. In a study of Kim, she and the group find out that the bleb-related infection was about 2% at 10 years. And the bleb leak early and late are the risk factors for bleb infection, and the bleb revision shows some protective role against bleb infection. Choroidal detachment could happen in any hypotonic eyes after intraocular surgeries, and including trabeculectomy, and the big IOP reduction is a main risk factor for the choroidal detachment after trabeculectomy, according to a study of Iwasaki. And this is the Sydney Eye Hospital data comparing two groups after trabeculectomy, hypotony and control group. And maculopathy was more prevalent, and the most was more prevalent in the hypotony group, which account for more than 23%, followed by choroidal effusion. And the author group concluded that a definition of hypotony that combines IOP criteria with the presence of structural or functional changes. In a study of a Japanese group, they try to find the new cutoff value for hypotonic maculopathy. And they find out that in the group, the patients with pressure from 7 to 10, there was a certain percentage of hypotonic maculopathy. And this is the illustration in the right side, which is the clinical hypotony we can see by clinical examination. But in the left side, it looks normal in the fundus, but it still presents as hypotonic maculopathy in OCT. And by ROC curve analysis, they find out that IOP less than 6 is the conventional or say statistical hypotony, and the range from 7 to 10 could be a subclinical hypotony. In a study of Yadgari, they follow up the patient after trabeculectomy with and without choroidal effusion, and they find out that the pressure in the choroidal effusion group tend to increase by time after 5-year follow-up. And the number of medication in the group without choroidal detachment seems to be less than the group with choroidal detachment. By analyzing the survival rate of two groups, they find out that the patients with choroidal detachment are more likely to have failed trabeculectomy than the other group. And the lesson learned for this case is we need to have a good ocular surface care for the trabeculectomy patient to prevent any uneventful rubbing. And we always have to find leak in post-trabeculectomy ocular hypotony with fluorescein 2%, which is better than 0.25%. We need to get scleropatch graft or pseudoblast ready when we do the Bleb revision. And we need to closely monitor the pressure after revision to restart glaucoma drops or even to perform the secondary glaucoma surgery. And we need to prepare for the secondary bevel tube or diode laser after we revise the Bleb. And that's the end of my presentation. Thank you.